Hi, good evening, everybody. A warm welcome to all of you, and I'm really honored to have all of you here on this particular platform. Also, I obviously appreciate that all of you have a very busy schedule and you are devoting time to this educational endeavor, which Dr. Fobi and myself and all of us are organizing it. And your contribution is very, very much appreciated on this platform. Having said that, I think we still have time. We'll start with the video. Okay, Himanshu, start. Everybody, in fact, good morning, good evening, good afternoon. We have been honored enough to be connected to faculty from all across the world in different time zones. So I once again welcome all of you to the episode 8 of the virtual Bariatric University, an endeavor which myself and Professor Fobi, we carry forward with all of great group of faculty like you to disseminate the knowledge, skills, and know-abouts of bariatric and metabolic surgery to the entire world. So before I start to welcome our faculty, this episode today, the episode 8, is special because it deals with a little contentious issue, and that's do we really need to ban the mini gastric bypass? Or is there an indication for this particular procedure? There will be a lot of opinions and data which would be shared. But before I take you live towards the first part of our webinar, let me introduce you to our faculty today. I have with me on board Professor Karl Miller. Professor Karl Miller is a professor of surgery, and also he works at a private center in Salzburg in Austria and is a vice president of Obesity Academy of Austria. Karl is very experienced with over 22 years, which he spent in the field of bariatric and metabolic surgery. And he is one of the pioneers, I would say, the founding members of the bariatric surgery societies, not only in Austria, but across the world. And he presided over to the Austrian Society for Obesity and Metabolic Surgery from 2000 till 2015. Professor Miller also served as the president of the largest bariatric surgery organization, the IFSO, from 2010 to 11, and presided over the IFSO World Congress in Austria in 2015, which I and along with me, a lot of other surgeons attended, which was a phenomenal success. With Karl, I would say we have he's a great host. So I have attended 3 of his meetings. And those of you who would have attended it, you know that he used to organize the famous Alpine meeting at Salfeldine, which is a beautiful hill station. And Karl is a great host and a great teacher and a researcher. Welcome, Karl Miller, to this virtual Bariatric University episode 4. we would love to listen to you. Next, we have Professor Karl Rheinwalt. So Karl Rheinwalt is, again, a very senior bariatric surgeon. He's the head of Department of Obesity, Metabolic and Plastic Surgery at St. Franciscus Hospital in Cologne in Germany. And his university represents one of the only 5 certified centers of excellence in Germany. Again, Karl is very experienced with 30 years of experience in general, bariatric, and trauma surgery. And he basically started his focus in bariatric surgery in 2006. Karl is known to propagate OAGB MGB, started by Professor Chevalier in Paris in 2009. And this is a new procedure on which he worked a lot. And he's one of the very active members of our MGB OAGB club, and has done a lot of work for this particular procedure. And since last 10 years, he is very instrumental in organizing many workshops across the world to help us improve the gastric bypass technique and the concept of fast track in bariatric surgery. My memories with Karl go long back. I was one of the surgeons who operated at his beautiful hospital in 2018. And we enjoyed his hospitality with the MGB OAGB club meeting there, 2019, at his place in Cologne in Germany. And I once again welcome Karl, you to this virtual Bariatric University episode 4, and we look forward to listen to your wisdom. Next, we have Professor Chetan Parmar. He's a consultant and an associate professor in the University of London, and is the head of the Department of Surgery in the Whitington Hospital, which is under the NHS Trust in London. He's also the editor of Obesity Surgery, IBC newsletter, and in the BOMS, he is responsible for the Patient Safety Committee and an executive member of the MGB OAGB club. So Chetan is from India. He hails from Baroda, and now he is shining the Indian flag in London. We are so proud that he is there at the top of the globe, representing our country and representing his own city and state. And we love to have Chetan, and warm welcome to you. We know that you have a huge experience with MGB OAGB, and you have published a fantastic meta-analysis, and we would love to listen to your experience. Professor WahYang, again, is a president-elect for Young IFSO, and this is one of the organization which is very instrumental in promoting the young members of the international society, the IFSO, to inspire them to present their work, and WahYang would be leading this. He's a director of clinical research and training in Jinan University in the International Bariatric Center, and also the coordinator of the Chinese Obesity Metabolic Surgery Collaborative Database. So at present, he is a surgical specialist in the Department of Bariatric and Metabolic Surgery in Jinan University, which is the first affiliated hospital in Guangzhou in China. And we attended him and his hospitality with his great team at Guangzhou at the IFSO APC meeting. And I had the honor of operating at his hospital in Guangzhou. And we loved the entire team, the hospital, the facility. And I once again welcome WahYang to this virtual Bariatric University episode 8. And we look forward to his contributions to this particular meeting. Aparna Govil Bhaskar, a great friend. She is one of the most experienced bariatric metabolic surgeon from Mumbai, and she works with varied hospitals starting from Global to Apollo to Hinduja and to several other hospitals. Aparna is a chairperson for the Position Statement Committee in IFSO APC chapter. She's also invited speaker at most international and national conferences, and she is the co-founder of the Debarata Oro Foundation, which is a charitable foundation, and we are so proud of her work. Aparna is a great surgeon. Her surgical skills, I can vouch, are beyond par excellence. But at the same time, being a surgeon, she is, I would say, a very eloquent speaker and a prolific writer. So Aparna, we look forward. We are so proud to have you. And we look forward to your contributions to the VBU episode 8. A warm welcome to you. Last but not the least, one of the surgeons who have inspired generation by his speeches, by his, I would say, a very different style of delivery of his speech, his lectures, which leaves the public spellbound, Dr. Bhatia. I would say Parveen Bhatia. He likes to, not Praveen, it's Parveen Bhatia, the leading laparoscopic surgeon in India, the teachers of teachers, has trained maybe thousands of laparoscopic surgeons under him. He authored 3 books, The Laparoscopic Hernia Repair, The Art of Endosuturing, which I can tell you as a postgraduate was my favorite book. So I've been following Dr. Parveen Bhatia since my postgraduate days when I learned the suturing, reading his books, The Comprehensive Laparoscopic Surgery, the 3rd book which he wrote. He also serves as on the editorial board of the Journal of Minimal Access Surgery, which is the journal by IAGS. His surgical experience and flair of teaching has given him accord from over 500 nationals and international conferences and workshops. And he is known to everybody in India. And I can say so much so that people look forward to hear from him. A warm welcome to a teacher, Dr. Parveen Bhatia, to the 8th episode of Virtual Bariatric University. Now, without much ado, I would say myself and Dr. Fobi, we are honored to have all of you. And I would like Dr. Chetan Parmar, Dr.WahYang, and Dr. Parveen Bhatia to moderate the first session, the first lecture, and welcome the first set of moderators. Please start.
Hello, good day everyone. Happy Diwali and a happy New Year. And thank you, Mohit, for an very kind words and introduction. Wasting no time, I'll obviously invite Professor Karl Miller to give his first talk, which is about long-term outcomes with banded OAGB MGB. Professor Karl Miller.
Yeah, thank you very much, first of all, for the kind invitation, and happy Diwali. I would love if you allow me to share my screen, then I can start, because it says on one participant can share at the time.
Yeah, now you can share your screen. We made you the co-host. Can you share?
No.
No? We have already made you the co-host, so you can do it once again.
It says one participant can
Yeah,
share.
now it says Karl Miller is the host.
Yeah, now you are the host. You can share it now.
Wonderful. I think it will work perfectly.
Yes.
Now. Thank
Yes.
you.
Perfect, perfect. We can see your slides there.
Great. So I'm really pleased and proud to share the humble experience, because aside from being a surgeon, I have to disclose that I'm consulting as Chief Medical Officer for Johnson & Johnson Middle East, but my presentation today does not represent the meaning and the policy from the company. So according to the disclosure of the International Federation, I have to disclose also that the majority of my procedures are Roux-en-Y gastric bypass still, and one anastomosis gastric bypass is really only for selected cases. So the background is one problem that in Austria we are confronted with a big number of really super obese patients. And my first procedure was 1992 with the gastric band in a super obese, according to my teacher and mentor, Emmanuel Hell, who performed a lot of vertical banded gastroplasties. So, however, it is a very, let's say, well-known experience from you all guys that super obese are not doing as well as the, so to say, normal morbid obese people. On the other hand, the life expectancy and, of course, moreover, the quality of life of those patients are really absolutely diminished and very affected, but even significantly shorter in their life expectancy. So based on that, we all learned Rutledge, and I invited him several times to the meetings in Saalfelden. And it was always a pleasure to hear his statements that the band sleeve Roux-en-Y are failed form of gastric bariatric surgery. And the mini gastric bypass was at that time, from his point of view, the best procedure. And he always stated that it is not a malabsorptive procedure, which was really on the big discussion by all the experts. So on the other side, there was always a group of surgeons that promoted the banded gastric bypass because it should avoid the expansion or the dilatation of the pouch, which was always considered as one of the reasons of weight gain or weight regain or insufficient weight loss. So Henry Buchwald summarized in a very nice review quite a long time ago that the banded gastric bypass had really almost the same weight loss result than biliopancreatic diversion and duodenal switch. So that was, let's say, the background. And when you look on all the comparative studies, and there are very few randomized, but those studies always showed, as you could see in this forest plot, a significant favor for the banded gastric bypass. So I was always astonished at that time why it is not the standard for all of us. And I think Mal knows very well that I inherited from Emanuel Hell a lot of patients with a vertical banded gastroplasty that I had to revise, and almost half of them I had to do a redo surgery, either for staple line disruption or pouch dilatation. But I have to admit that this kind of non-adjustable band on this sleeve here is pretty tight compared to that what we will talk today about. And also Konrad Kars published in his banded sleeve not the best experiences. So it is really, let's say, a learning process that we have to share when it comes to a banded restrictive procedure. So having said that, I think you all know Nicolas Copinaro, God bless his soul, that he always said, and that's absolutely true, don't add a restriction to a malabsorptive procedure. So based on that, I started having a discussion with our ethics committee in Salzburg, which is, or which was a very, very difficult and long discussion, because I wanted to find for our super obese patients something that is more effective and more powerful than that what we had in that time. Because I had also with Rutledge a one-on-one discussion, and he said sometimes even 2 meters of biliary limb is not long enough. And he did revise patients with 2 meters to 2 meters 30 or even more, but this is a one-on-one conversation, and it was never really wonderful published so that we could have better information on that. So in addition to that, the ethics committee said there is no data on a banded one anastomosis gastric bypass, which is a less one anastomosis gastric bypass, a less risky procedure in those extreme obese patients, which is really difficult to do a classic Roux-en-Y gastric bypass sometimes. So in that time, We had also at that time very controversial results with restrictive procedures in this patients group. There were very little studies at that time. Most of them were observational, and in addition, for the banded Roux-en-Y gastric bypass, there was not really a standard where we could follow at that time. On that conversation, the social insurance then covered the procedures and also the potential reoperation. They insisted on a 24 hours observation at the intensive care unit. Based on that, it was not a standardized procedure and quite a risky patient group. In addition, they said you are limited to 10 patients as a pilot study. And in addition, then after once we started, we got the approval for 12 patients as a pilot study. And I have really to address that this was or is an investigator study where no financial support from any industry, neither from the company where I used the stapler, nor the reinforce, nor the band got any financial support. So the basic was, as I think you could read also in the paper, that those patients had a very extensive workup pre and peri-operative with dietitian and our psychologist group. The gastroscopy was mandatory. We had, of course, a higher enoxaparin dose the night before we started and followed 14 days. There were used pneumatic antithrombotic stockings, and so on and so on. So the gastric tube was at that time 36, but we did not move very, very close to the tube. So we had really a tight tube, but without any tension on the tube. We started distally to the crow's feet or the pes anserinus. We used 40 to 50 millimeter staple line vertically to the lesser curve. Then we continued in the direction of the angle of his, but as you could see, those patients were really very, very obese, as you see in the fat type inside. The last staple lines to the angle of his were reinforced because, as mentioned before, I was always scared with a high pressure a tube where you could create a staple line or leakage. So having said that, we started 5 centimeter distal of the esophagogastric junction, very close to the stomach wall, creating a very, very small entrance to the lesser sac. I think you will see anyway the procedure, so I will continue a little bit ahead of time. What I would like to address also is that we used a little bit wider band and a very soft one. So that is what I was, let's say, very attracted when I saw this kind of band. It's the MID band. However, I think you have, regarding bands, a lot of possibilities and devices available. The length was adjusted in between 7.5 and 8. To my documentation, we used at that time the biggest size that we could get, and that was 8 centimeter. The locking mechanism is very simple and also adjustable according to the size. So we had still, when we adjust and size the length, the tube in the pouch. So once you locked it, the anastomosis was performed just to double check the blood supply and the band is really loose. So I'm the one who loves stay sutures. You will see very faster procedures, but that allows me with those stay sutures a very standardized procedure, opening of the pouch and opening of the small bowel, bringing in the linear stapler to 4 centimeter and closure of the defect at that time with Vicryl, 3-0 from both edges, so one from the distal edge, one from the proximal edge, and I tied it in the middle. Meanwhile, I'm using a atraumatic barbed suture, namely Stratafix, which goes from the lower edge in one layer up to the upper edge. That was after that, of course, doing the leak test, and as you could see, beginning from the upper edge to the lower edge and tying in the middle. So that is very briefly the procedure. We had an average BMI of 57 in those 12 patients, which moved down after 5 years to 31.2. And as you could see, we had diabetics who we knew that were diabetics in 40. But on the other hand, the HbA1c level was as usual. In 1 out of 2 patients, diabetics were not identified before surgery, before admittance. So we had a significant reduction in those comorbidities, especially what it meant with diabetes, and even in high blood pressure. Per definition, we had a significant reduction in that from. But as you could see, the blood pressure itself is not that impressive in the reduction. We had 3 complications where I had to remove the band. It was basically intolerance in 1 patient and malnutrition where the albumin level was really very, very low. So I had to remove the band and shorten the length to 1.60 meters. That went very well, by the way. And 1 patient had severe iron deficiency, and the rest of like dumping or mild hypoalbuminemia could manage with our dietitian. So I would like to thank also our team, the nutritionists and the psychologists that also investigated the barrows, which I do not figure today because of the lack of time. But the quality of life is absolutely comparable to that non-banded group that we had done studies with bypass, with BBGs, with bands. So the banded gastric bypass patients, those who had their band in those are extremely content and happy. So what I would like to say from what did we learn the 5 years, that the band should be not as tight as the BBG bands. It's very important that you select carefully your patients that are pre-operatively seen, that had pre-operatively seen a psychologist and of course dietitian. The dietary and counseling is extremely important, and it is absolutely crucial that we should collect more data. I really insist, and I think we will hear in one of the next presentations a very exciting randomized study. I'm looking forward to that, but I can tell you from the long term, those patients who are coping very well, who are, let's say, following the rules and regulations of eating and nutritional counseling and supplementation, they are doing very, very well, and they came down to a really reasonable body mass index with no comorbidities from the meaning of diabetes or also sleep apnea. Yeah, thank you very much. I think that's my part for today, and I would like to be available for the discussion.
Thank you very much, Professor Miller. That was an excellent talk, and I think You're correct. Super obese and super obese. And I think, again, for those juniors who are there, BMI greater than 50 and BMI greater than 60, it's always challenging decision. What is the best procedure? I think you have to look at the technicality as well. And I think this pilot study was done way back many years, I gather 2011 or 12. So that was many years ago. So that's quite commendable. A couple of points, I think, when you said a careful selection of patients, you did a pre-operative endoscopy in all those patients, Professor Miller. And I think, does that play a role in the patient selection? Like whether would you do for somebody who had esophagitis or a hiatus hernia, would you offer this bended mini bypass? And the main reason I'm asking that is, as we know, when we talk of a mini or one anastomosis gastric bypass, there is always question of reflux.
Yeah, I cannot answer that question because it was mandatory from the ethics committee that those patients were healthy in their esophagus, in their esophagogastric junction, and in their stomach. So no pre-operation before, no reflux obvious, either symptomatic nor endoscopically seen. So that was the requirement from the ethics committee, that we take also psychological stable patients who are committing to the dietary instructions, and we need to have a certification from the psychologist. Yes, this patient is from our side suitable for restrictive procedure.
Thank you. And just one more question before I pass on. I think you mentioned 25% of the patient needed band removal. Would you do something different to what you did in your pilot study now? Because I think 3 patients needed band removal. So would you do something different?
No, they only had slightly weight gain, yes, but they were under nutritional counseling. So I think the main important point was they lost really significantly weight. And our goal was to maintain this weight loss. So it was only in one patient where I had to reduce the length of the biliary limb because of really severe hypoalbuminemia, and I removed the band and shortened the. So this patient was the only one who gained weight in this series. The details you can read in the paper, but that was the only patient who gains weight, and at the moment I don't know what to do with him.
Okay, thank you very much. And now I'll invite Dr. Bhatia and Dr. Wong to have some questions for Professor Miller.
Thank you very much. Dr. Miller, enjoyed your presentation as always. What is your thought process about patients who are having alcohol and who are smokers or who are smokers?
It would be, I would say, I would be a racistic personality if I exclude those patients. They are also suffering from their weight, but it's in the information that they have more likely ulcers, they have more likely post-operative complications. But however, I try to motivate them to skip at least 2 to 3 weeks before surgery, and anyway, it's everyone's personal choice how he. But my profession is to help him with his weight. I'm not the psychologist who will people forbid smoking. But anyway, I would just warn, and it's in the informed consent written, that those patients do have a higher risk on marginal ulcers.
No, most of the surgeons, in US especially, they always say that we would not operate if you do not stop smoking, or if you do not.
That's different. If I would be a plastic surgeon and I do plastic surgery, the wound healing is really awesome. It's not good, but I'm operating on their comorbidities, and at least I could remove one comorbidity, and that is morbid obesity. and most probably also the diabetes. So what we also saw in some of our other patients, not in this study group, that those who are smokers, when they start losing weight, they got so motivated, they start doing sport, that they change their life completely. So you never know what you achieve with your surgery.
Sure, excellent. Dr. Yang, please.
Thank you very much for Dr. Miller to share with us your great experience. I read your paper from the obesity surgery. It's a pilot study. May I ask, do you have any plan to start some international multi-center study for band OAGB, or do you have any plans? As we are still lack of data, we need more data to support this kind of procedure.
I think the idea would be great for younger surgeons. What I do, I proctor surgeon how to implant that, and because that is really a selected patient group where you don't do every day a banded one anastomosis gastric bypass. So therefore, I do more proctoring than thinking on that. I have other studies at the moment where I'm responsible. So I would love to add my experience on that. But I think that would be great for younger surgeons because we need longer follow-up. And let's say in 3, 4, or 5 years, I will retire, and I don't know if my motivation will be that enormous regarding doing studies.
Please let us know if you got any new studies in your team.
Okay, absolutely, yeah.
Thank you.
Thank you. Thank you, Dr. Miller, for an excellent presentation. All of us enjoyed. And now I would request Dr. Shashank Trivedi. Dr. Shashank Trivedi is going to present on prospective comparative study between one anastomosis gastric bypass vis-a-vis banded one anastomosis gastric bypass in super obese. Dr. Shashank is doing fellowship in Mohit Bariatrics and Robotic Surgery Center, Indore. Dr. Shashank Trivedi, please.
Regards from Institute and Mohit Bariatrics. So those are disclosures we have to make. Dr. Fobi is the founding president of the Bariatric Corporation, which is a band making company. Dr. Bhandari is consultant to various institutes from J&J to Olympus, and this has no impact on our study. Total number of patients, the graph is showing till the September 2020. So we have around experience of 5,000 OAGB, out of which thousands are the banded ones. So this was the primary first time when Dr. Rutledge introduced the OAGB procedure, which is a single anastomosis gastric bypass. What he suggested was to make a long and slender pouch, a gastric pouch of around 15 to 18 centimeter length with a 2.5 centimeter width. BP limb of more than 200 centimeters and 3 to 4 centimeter of the gastroenterostomy. After the introduction, this procedure got very widely accepted all around the globe. Numbers were increasing because of the technical ease to perform. And it was very simple and effective treatment for the morbid obesity as well. The comorbidities along with coordinated with the morbid obesity. There have been several studies showing that the weight loss outcomes are equivalent or better than Roux-en-Y gastric bypass, which is a gold standard. The BP limb length holds the crux of the success of the surgery, which has been varied from more than 200 centimeter to 150 centimeters. There have been studies which suggest the tailored approach to the BP limb length as well, and it has directly correlation with the significant weight loss and malnutrition. There have been studies which mentions that the MGB holds highest percentage of the malnutrition of around 13.1% compared to 2% in the Roux-en-Y gastric bypass. Talking about the revision of the MGB, the malnutrition holds the highest rank as a reason for the revision, which is around 40%, followed by inadequate weight loss and weight regain in around 35% patients. The intractable bile reflux and dissatisfaction caused by that also causes us to do the revision in the MGB. So looking at these results and we analyzed our data of the last few years that suggested that in the super obese category, when the OAGB was done in the patients of more than 50, BMI of more than 50, there was a weight regain in around after 5 years. So we made these changes in our protocol. We do not recommend OAGB in patients with BMI of less than 40 because of the high incidence of the PCM and expected weight loss, excessive weight loss. The standardized BPLM at around 180 centimeter in all the OAGB operations to minimize the protein caloric malnutrition. After Dr. Fobi introduced the placing a band in the RYGB gastric pouch, and shows excellent results which were published, and there were so many papers on that. So we also introduced to place a band around the OAGB pouch approximately 3 to 4 centimeter from the gastroesophageal junction, which helped to enhance the weight loss and maintain as well. These all were done in the patients of the BMI more than 50. We collected all the data and published the results every yearly. So this is a diagrammatic presentation where we place the ring around 3 to 4 centimeter from the GE junction. The ring or the band is either commercially available one, or we put the surgeon made rings. We standardized the BP limb at 180 centimeter as well. The objective of the study was to describe the surgical technique and report the results and compare it with the non-banded OAGB. So as I have mentioned the surgical technique, we perform OAGBs like that and put a ring at around 3 to 4 centimeters from the GE junction. We collected the data and retrospectively analyzed. Looking at the demographies of the data, there were 131 patients in the non-banded OAGB, whereas there were 191 patients in the banded OAGB. The BMI, the average BMI in both the groups was around 55 to 56. Talking about the incidences of the Co Mobilities, the type 2 diabetes mellitus was found to be in 30% of the patients in the non-banded group, whereas 32% in the banded group. The hypertension incidence was significantly higher in the banded group, which was 32%, whereas it was only 60% in the non-banded group. The other comorbidities which were taken into the account in this study were cardiovascular disease, obstructive sleep apnea, thyroid disorders, joint pain, and backache. We followed up the patient at the 6 months, 1 year, first for the 6 months and then every year. So total, there was nearly 100% follow-up for the first 6 months in both the groups, which gradually decreased to 63.6% in the banded group and 62.8% in the non-banded group. Talking about the results of the procedure, the percentage total body weight loss was around 23.56 in the banded group, whereas it was 22.23% in the non-banded group, which was not significant. But by the end of the first year, we started observing significant difference in the percentage total body weight loss, which was 27.04 in the banded group at the 1 year and 24.33 in the non-banded group. By the 3 year, again, we observed a significant difference. In there was 36.49% weight loss, total body weight loss in the banded group, whereas it was 32.12% in the non-banded group. Making the numbers easy to understand, the graphs, blue line depicting the banded group and the orange line depicting the non-banded. Lines going similar, the both procedures showed weight loss significantly, with the significant difference in both the procedures. Percentage excess body weight loss, again, same like the total body weight loss. There was, at the 6 months, there was no significant difference was found between both the procedures. There was 67% percentage EBWL in banded group, whereas it was 65% in the non-banded group. By the end of 1 year, just like the total body weight loss, we also observed a significant difference at the end of the first year, which continued till the 3rd year and raised to around 80.59% in the banded group and 76.08% in the non-banded group. Again, the graphs showing the same thing, that there was a significant difference at the end of, by the end of the first year. The nutritional deficiencies that were taken into the account in all the follow-up were hemoglobin for the anemia, low protein albuminemia, vitamin D3, B12, and calcium. There were 11 patients out of the 61 patients at the follow-up at the 3 years showing anemia, which was 7.1% in the non-banded group. Whereas in the banded group, only 1 patient out of the 14 followed-up patient at 3 years showed anemia, but the percentage-wise, it was equal and there was no significant difference. Low albumin, that albumin deficiency was found in one patient out of 61 in the OAGB group, while it was not found in the banded group. Vitamin B12 deficiency was found in 2 patients, which accounted for 3.2% in the non-banded group, whereas in the banded group, it was not found in any of the patients. The resolution of the comorbidities also holds the success of the surgery. The type 2 diabetes resolution was found in around 79% in the non-banded group, whereas in 87% in the banded group, which was significance. The same significance was found in the resolution of hypertension and obstructive sleep apnea, accounting for 66% in the non-banded and 87% in the banded, whereas sleep apnea was resolved in 75% in the non-banded and it was 100% resolved in the banded group, which was significant. The food intolerance in both the groups, there's so many numbers on the single slide, but if I'm just looking at the food intolerance for the banded procedure at the 1 year was at the 6 months was 50.3%, which decreased to 32% at 1 year, 23% at 2nd year, and 18% at 3rd year. In the OAGB group as well, it decreased gradually from 26 to 6.2%, which shows how the patient accommodates themselves and how to adapt to a new lifestyle after this procedure. The quality of life, speaking in terms of regurgitation, nausea, vomiting, and difficulty swallowing, it showed no significant difference in both the groups after 2nd and 3rd year. By the first 6 months and the 1 year, there was equal number of these complications, but by the 2nd year, it was not showing any significant difference in both the procedures. The complications, the marginal ulcer were found in around 9% of the patients, which accounted for the 4.7%. And in the banded group. In non-banded group, it was found in 8 patients, which accounted for 6.6%. These were symptomatically patients who presented with some complaint of the pain. Diagnostic endoscopy was done and the marginal ulcers was found. Looking at the higher incidences of the marginal ulcer, we started doing a surveillance endoscopy from 2019. Which showed gradually increase in the numbers of the marginal ulcer cases, which was accounting from around 10 to 15% more that we will be publishing in the next study. The efferent limb obstruction was found in 1 patient under POD 3rd. There was a gross distension of the abdomen and was treated with the Brown jejunostomy. 1 patient presented 1.5 years around with the complaint of pain, and there was band erosion was found, which was removed endoscopically. There were 2 patients who required band removal due to severe food intolerance. So total there were 3 patients in the banded group which required a band removal due to one or another reason. Looking at all the results, we concluded the banded 1 anastomosis gastric bypass is safe and doable operation with complication rate comparable to the non-banded procedure. The placement of a ring or band appears to increase the percentage total body weight loss as well excess body weight loss. There are few patients who comes with a complaint of the food intolerance due to band, but they can be managed by the nutritional counseling. Definitely they require multiple counseling for the same thing, but they do good with the counseling only. And there are very few patients who required band removal because of the intolerance. And this is a data of the 3-year follow-up, which by the end of the 3 year, the follow-up decreased to around 14 patients and the 61 patient in the another group. So definitely we require the more long-term follow-up data and multi-center trials as well to determine the long-term efficacy of this procedure. Thank you.
Please.
Thank you, everyone.
Yeah, thank you, Shashank. Dr. Yang.
Do you have any questions?
Any questions, anything?
Thank you, Shashank, for your data. Actually, I'm not worried about the technical issue. May I ask, the problem is how to start? For example, in many countries, in many centers, they don't even do banding, no matter gastric banding in the past or now, banded bariatric surgery, banded sleeve, banded gastric bypass, and now banded OAGB. And in our center, we we just did several cases. Last time, 2 or 3 years ago, when Dr. Fobi and Dr. Mohit visited our hospital, they did some live surgeries, and Dr. Mohit gave us several Fobi rings, and we tried on several patients. The outcome are quite promising, but how to promote, for example, may I ask how to promote bariatric surgery in some countries, for example, in China, they even we don't even have bands in the market. And the problem is also how to convince our surgeons, bariatric surgeons, and how to convince the patient to accept the bands, because some of us may think that this is our foreign bodies. We don't really want to put some foreign bodies into our body. And especially, we need to convince the IRB to get the approval. For example, they usually mention that we don't even have data in our country. So how can you convince us to give you approval to perform the what we say new procedures to our patients? So may I ask our fellow doctors to share your experience, how to start?
More than 50.
Dr. Bhandari is ready for surgery, but I'll answer that briefly. Basically, you must be doing quite a few of banded procedures. And then you also need to see patients who are having weight regain. And in those cases, then you can show that banding the pouch will make a difference. If you have excellent results without banding the pouch, then absolutely nobody's going to be confused to place a band where it makes no difference. We were able to do it at Mohawk because at 5 years and beyond, we saw that patients with super obesity were gaining weight. And so we were able to let them know that they will benefit. And we had a lot of experience with banding the sleeve and the gastric bypass. And we offered to the patients, say, well, you're going to lose weight, but some of you will gain it. You are offered to have a ring if you want to, but if you don't want to, you don't have to. And so we are collecting this data. Dr. Miller is collecting data. Dr. Ramos is doing some work in Brazil. Dr. Clark and Booth are doing some work in Australia and New Zealand. And when this data is collected, people will be convinced. But until then, this is mostly, what I call now investigational in the super obese patient. I'll ask you, we were supposed to do a panel discussion, but the patient was induced, and I don't want to keep a patient under anesthesia. So if you permit me, I'll take us over now to the OR and let Dr. Bhandari do the procedure, and then we'll go from there to the panel discussion. Okay.
Thank you, Dr. Fobi. Thank you, Dr. Miller and Dr. Shashank for an excellent presentation. We are live from the OR, and I would like to invite Dr. Karl Rheinwalt and Dr. Aparna Govil Bhaskar to moderate this session. I have with us Dr. Manoj Reddy, who is the consultant at Mohawk Bariatrics and Robotics, and he'll be sharing the case details with you.
Hi everyone, welcome to Mohawk. I'll be presenting the brief case history. This is a 35-year-old male with a weight of 160 and BMI of 57.4, non-vegetarian, no addictions, and comorbidities include OA and OSA. Investigation show most of them are normal in limit, albumin 4.0 and HbA1c of 6.5 showing borderline diabetes, and viral emissions are negative. Even COVID-19 RT-PCR is negative, and ultrasound is showing grade 1 fatty hepatomegaly. And the rest of the investigations are within normal limits. This is RT-PCR test, which is given as negative. And Mohit sir is ready with endoscopy. We'll be seeing him in a short while.
Okay, so good evening, everybody. As you can see, I'm ready here with an endoscope. We perform intraoperative or rather pre-operative endoscopy for all our patients. As you can see here, I would want to rule out gross esophagitis and Barrett's esophagus. This is a Z line. I don't see esophagitis here while I pull it back. It's normal Z line. While we go inside, we would want to make sure that there are no gastric ulcers. Stomach looks pretty much normal to me here, except for the fact that I can say that there is a little bit of mild gastritis, but that's also fine. We don't see any gastric ulcer or any gastric polyp, any other growth. I am into the duodenum. We would want to rule out if there is any growth in the duodenum because of the fact that we know that we will not be able to access the bypassed part of the stomach very easily. So I'm going inside into the duodenum. I can see everything as far as I can see. I'm already into the initial part of the duodenum and then into the first, second, third, fourth part, and now into the regular intestine crossing the GE junction, DJ flexure, sorry. So this is, this looks fine, although I'm going to pull my scope back again to visualize if I have any pathology into the duodenum. This is looking good to me. We have seen the entire area until the DJ flexure. And while I pull my scope back, I have a better look of the duodenum. We are inside the stomach now. This is the pylorus here. I pull my scope further back, and while I pull it back, I would now want to see the hiatus. So this is the area of the hiatus. I would suck this little bit of bile which is there. This can also be done by a gastric calibration tube, but if we suck it by using the scope, it is a much better way. The retroflexion of the scope is done for the intention of checking if we have a hiatus hernia or we have a large defect into the crus which is present, which can cause problems later on. So I don't see that there is any here. I would like to pull my scope back at this stage and start the procedure. Before even we start the procedure, I would like to put the gastric calibration tube to remove the air which is there inside the stomach, and then we can start the position. Till the anesthetist evacuates the stomach, I would like to bring your attention to the port position. So if you can see here, I am standing on the right side of the patient. My assistant is between the legs of the patient, and the port position here, we have a optical port which is just above the umbilicus. We have two 12 mm ports. The one on the left side is on the anterior axillary line. The one on the right side is also in the anterior axillary line, but that's just at the level of the optical port. So one 10 mm optical and two 12 mm ports. I have two 5 mm ports, both 2 finger breadth below the subcostal margin on both right and left side in the anterior axillary line. So these are the total 5 ports I am working. I am using a 3 mm of a non-traumatic, non-scarring liver retractor here. Now we can switch the views inside and take the PIP here. So as you can see, the hiatus is good. The first step is always to see the hiatus, and that's fine. Now, as we know that the standard method of making the pouch of a mini gastric bypass is that we create this space into the lesser sac. And as you can see, this is the space which we created. The landmark to start this dissection is just at the level of the incisura. My first cartridge is always a gold. We were using a blue initially for the mini bypasses, but then we thought that this area is a little more thicker close to the antrum, just below the incisura. So this is the incisura here, and I'm going around 2.5 centimeters below the incisura. And while firing, we make sure that we are not obstructing the remnant and that remnant drains well. So that's the first firing, which is done by a gold cartridge, a little thicker, just for the purpose of not having the loose cartridges or having a staple misfire with the blue. The second firing is again done considering that we don't need to obstruct this area of the draining remnant. That is important because sometimes we can fire close here and this area cannot drain. As you can see, I have not inserted any tube as of now because I understand by visual perception that both the pouch and the remnant will drain effectively. As you can see, this is the remnant and that's the pouch. When I am doing my third firing with a blue reload, now I can request the anesthetist to come in with the tube. The tube is a 38 French size gastric calibration tube, which is available in, it is 36 to 38 French, but so that's what is available with us in our country here. And that's been made by the J&J. So that's the tube we all have been using. And this tube is being used for all our cases, for sleeves or for bypasses or for any other procedure. So the benefit of asking the anesthetist to come in after the second reload being fired is that he can easily find his way into the tube because the passage is already made. So as you can see, there is a little bit of redundancy there in the tube. Now we would not want to take that redundancy because we are going to put a ring here. And even if we were not to put a ring, we would want to exclude as much as fundus as possible. So this is something different which I usually perform. I do not use a lot of harmonic or energy source here. As you can see, we are doing some retrogastric dissection and this thing here is ready. So I can come in and just hold this area there and then take as much as of the fundus as possible. So you can see that I am already there and without using the harmonic, because I have seen some surgeons use a lot of harmonic and energy source at this area. That's something which we try and avoid. So as you can see here, absolutely no energy source in that area, and I can create a retrogastric tunnel. We still have one more cartridge to be fired. So you can see I'm working at the area of the spleen. I'll be more cautious here, but I have created that space. Plus the visualization is beautiful, as you can see here. Some surgeons use a gold finger, which is good. You can also use a simple grasper. If you don't have a gold finger, there is no need. Just use
Mohit?
Yes.
From which stroker you are firing now? From the right side on the patient or the left side?
Okay.
Which stroker?
So I'm firing all my, so I hope you are getting the PIP. Just focus on the PIP. So if you can see,
okay,
all my firings from the right side. So I stand on the right side.
Okay, thank you. Thanks.
Just focus me. So just put the PIP there. So you can see that I am standing on the right side. My assistant is between the legs of the patient, and just show the trocar position now. Yeah. So now you can see that I'm firing, all my firings are done from the right side. Is that more clearer now?
Yes, it's clear. It's clear. Thank you very much. Thank you.
All these firings are done. Can you push the bougie, please? Keep pushing. Keep pushing. Keep pushing. Keep pushing. Keep pushing. Push. Don't be afraid. Push. Okay. Now, this, if you see, this here is my pouch which I created, and that's why I was saying that we have been using the blue all around, and blue is good enough at this particular area. Our blood pressure is a little high here, so we might have some oozing, but I always prefer a little higher blood pressure, maybe 140 or 150 while we are firing, because the most common complication we recognized in a mini gastric bypass is bleeding from these staple lines, and they are on both the sides. So our anesthetist specifically keeps the blood pressure a little higher. 140 is good enough to start the firing, so that if there is any significant bleeding which you get, it's gonna show you at the same time and not gonna come later on as a surprise while the patient is into the emergency, or maybe in the night when the patient gets up and have. So this at 140 or 150 of BP, I'll be very satisfied with this kind of an approach. Now we keep 2 gauze here just because most of the time this oozing settles on itself. We need not waste time too much in doing the hemostasis. At the same time, we now would create a perigastric space to put a band. So the first thing is we should try and measure the area from where we need to put it. So this is the G junction here, as all of you can see. I would like to restrict myself to 3.5. So this would be the area. So my working area would be this. I'm not going to go below this area. I would even prefer to go a little above this. So this is nice. And in fact, what I realized that most times you may create a defect below, but when you go inside, you can place a ring a little above. So even though you create a defect at 4 centimeters, the ring is actually at 3, which I will demonstrate. So a little bit of oozing is there because this is a little vascular part of the thing. And as you can see that we are there on the other side with the grasper. And this is simple dissection. I am not using too much of harmonic here, a little bit just to avoid a lot of bleeding. There is always some bit of bleeding from the perigastric vessels. We all, those of us who do a perigastric approach for a gastric bypass, we know that when we create and work at that space, there is some bit of oozing there. That's okay, we can manage it. At most times, if there is not a big oozer or a large vessel involved, maybe a large gastric vein, most times it is taken care of by just putting a gauze there. So you can see that I have slots of 8, 7.5 and 7. So I'm going to put it at 8 here because I want it to be loose around the pouch. So you can see this is loose. And this bleeding which is here, I hope it stops. So I'll put a gauze here, and then this gauze, while I come back after doing the anastomosis, by that time I won't find that oozing. But here I'm going to cut the 2 ends of the ring so that I can remove them right now and I don't have to come again later on to remove it. So you can see I am cutting it at one of the slots there, and the minimizer ring which we are using today has one of the important advantages of having a socket for us to fix that ring. So there is a fixation there. So I can fix it now and straight away measure the area which I already explained that where we are going to fix. So you can see I made a perigastric space somewhere around 4 centimeters, but now when I'm trying to fix it, I can go a little above. So the assistant can hold it for me, and you see this is the beauty of this ring, that I get this nice socket to fix this ring. So I don't have to sort of go back and forth searching for a place, and plus it is more secured than what most surgeons would try to achieve it by other rings. So that's the beauty.
What kind of suture you use? What kind of suture is it?
This is simple silk.
Silk, okay.
Simple silk which I'm using, and we have been fixing most of our rings with silk, and it is a good non-absorbable suture. One can use a PDS here. I was asked by another surgeon who used Proline here. So it's okay, whatever you use. Now let me have a ruler again. So you see the bleeding there has already stopped. That was what I was trying to mention, that most times the bleeding is going to stop. We still have the blood pressure at 140, which is very important. We don't want a false sense of security. So I always ask them to keep it at 140, even in the live workshops, because those are the times where you make most mistakes. Now you see, as Dr. Fobi wants us to do everything with measurement, not what we think, but what we see and what we demonstrate. So this is 3 centimeters, and that's the shortest possible proximal pouch we can give. So now you see this is 10 centimeters here, the length of the pouch, and the length of my, total length of my pouch would be around, you can say, I would say it around 15.5 or 16 centimeters in total. But we again going to measure the length of this pouch once we complete our anastomosis. Keep pushing the bougie. So the bougie is pushed. I would be inclined in removing this particular pad of fat because I feel that it causes a little bit of bleeding when I fire. I would do a posterior anastomosis here, and once I remove this bit of fat, it is always better for me because that avoids causing hematomas with my stapler. So that's it. We don't need more clearance than that. I'm going to use the tip of this particular pouch to create a gastrotomy. so that I incorporate this strip and a little congested area into my gastrotomy, enterotomy complex while I do the anastomosis. Keep pushing the bougie, keep pushing. So while the anesthetist is pushing the bougie, you can see that I can see the blue tip of the 38 French tube. I'm not going to go beyond this because I know I've made a gastrotomy now. And this is the time we're going to rotate this transverse colon towards the pouch and just try and ask the anesthetist to make this patient a little bit more supine. So that's supine. Now you see this is the landmark. This is the landmark here. There are two landmarks. The first one is obviously the ligament of Treitz, and the second is the inferior mesenteric vein. You can see here, that's the inferior mesenteric vein there. That's the inferior mesenteric vein, nicely seen, and that's the Treitz. Another point I wanted to make, we did an endoscopy, but you see the bowel, it's not dilated. So you can do intraoperative endoscopy just before the procedure. So my way of estimating it is that I marked two of my graspers. This is 10 centimeters, these two marks. Simple, I just kept it very simple. So what we're gonna do, this is 10, that's 20, 30, 40, 50, 60, 70, 80, 90, 100, 110, 120, 130, 140, 150, 160, 170, and that's 180. So 180 centimeters is a standard limb length which we choose at our center. Now, as you have seen in Dr. Miller's lecture, that both restriction and malabsorption should not be combined, what Professor Scopinaro used to say. And so we are not going beyond 180 centimeters. This is a super obese patient, BMI 53, but we won't go beyond 180 centimeters. We won't go to a limb length where we leave a common channel of less than 400 centimeters for this patient. You can see that by the consistency of this small bowel, we are still at the jejunum. And obviously, because we are doing less than 200 centimeters of bypass with accurate measurement, I'm not going to measure the common channel. So, yeah.
Hi, just wanted to know what will be the size of the anastomosis?
That would be a full 6 centimeters, but while we suture it completely, so this is almost complete length we took, but while we suture it, it reduces to around 4.5. But eventually I feel that the effect would not be more than 2.5 because the distal part of the anastomosis would be determined by this area here. And if you see this, this is 2.5. So I use a full length, but by the time I suture, it becomes 4.5. But the effect, the original effect, if you consider it as a form of the anatomy, is the determinant is this diameter of this bowel. That's around 2.5 centimeters. So now you can, the correct answer to your question would be that my size of my anastomosis, the length of my reload being fired to make an anastomosis would be 6. It eventually would be 4.5 after suturing, but the effective diameter which remains as a consequence would be determined by the diameter of the bowel distally would be around 2.5 to 3 centimeters.
Not very sure I agree with you on that because I feel that it will still be a very big anastomosis, and if you're applying a ring above, then you can definitely go shorter on the anastomosis part.
Yeah, what I feel is that if you have a ring, does it matter what is the size of your anastomosis?
Yeah, I mean then why have a ring? I mean, if you can
Yeah.
It doesn't, somehow it doesn't, logically, it doesn't make sense to have such a big anastomosis and then place a ring above.
So I will tell you why we are not making it more restrictive here in terms of the anastomosis, because by gastric bypass or by banded gastric bypass we have learned that initially when we were doing a non-banded gastric bypass, the size of the anastomosis had to be 1.5 centimeters to 2 centimeters. Now with the band in place, all of us are making an anastomosis of 2.5 to 3 centimeters, even in our gastric bypass, because the band does not sort of allows the weight regain or does not allow the patient to eat into the roux limb. So learning from our experience that the size of the anastomosis would not matter. If you put a band, we still make the same 4.5 to 5 centimeters here. That's what is the, if you ask in terms of the data now, if you make it around 2 centimeters or 2.5, then probably you are making this procedure a little more stronger maybe. But then in that particular case, this is not required with our data from gastric bypass. That's what I can say.
I gather what Aparna is probably trying to say, that you have a 15 centimeter pouch and then you are doing a 6 centimeter anastomosis. Is that what Aparna you are trying to say? That means you're already going up to say 10 centimeter in the pouch and then you have a ring above that.
I mean, to me, it sounds like a very confused procedure. I mean, I'm sorry, but it doesn't make sense to me.
No, but you are confused with the mini gastric bypass as a procedure, or you are confused with the banded mini gastric?
I'm confused with the band on the mini gastric bypass. I'm sorry, I'm playing the devil's advocate here.
No, you have to
I'm all for new procedures, but I just feel
my answer here would be that we are not concerned about the size of this anastomosis being more than 2.5. So first I'll answer your part of question. So we have some data from gastric bypass that most gastric bypasses are now around 2.5 to 3 centimeters, and because of the band, the chances of patient eating into the roux limb or the chances of pouch getting dilated or having a large reservoir is reduced. So it does not matter what is the size of your anastomosis if you are putting a ring. The same principle applies to mini gastric bypass. There is no confusion here. So we do not bother about this size, because number one, at the end of the day, the eventual size which would matter here would be the distal bowel of the distal diameter of the distal bowel, the number one. Number two, if you put a band, why bother about the size of the anastomosis you are making? That's what we learned from gastric bypass, and we are trying to apply the same principle here. Now, as far as the question which Chetan was asking is that if you make such a large anastomosis here, what you made, you already encroached upon most of the pouch, so he's concerned about the reflux. So we have some data. We do not think that the length of the pouch is in any way determinant of the reflux which you have. It is the strength of the lower esophageal sphincter which is determinant of the reflux which you will have. So eventually, this is the area of my pouch above which I'm going to calculate the length of my pouch. So if you see, my anastomosis is of a size, if we start to measure, it would be around 3.5 to 4. The length of the pouch above the anastomosis here, if we start to measure it, this being 10, and I would say if I keep my grasper here, this is another 2.5 to 3, so it's around 13 centimeters is the length of pouch. So I don't think that the length of pouch above the anastomosis matters in terms of reflux. 13 versus the 18, you can try to make as long as pouch as possible, but if the lower esophageal sphincter is defective, even in those particular cases, you may end up having a pretty large amount of reflux. And even if you make a short pouch and if the LES is competent enough, it's not going to give that much amount of bile reflux, or there would be no bile reflux eventually into the esophagus, is what we feel. As far as what Aparna said about putting in a band and making a very small anastomosis, I think with the 180 centimeters of a bypass, that would be too restrictive a procedure. Plus, I don't think that it makes too much of a sense to make it 1.5 like we do in a gastric bypass, because at the end of the day, this is the determining diameter of the bowel here, which I would feel is around 2.5 to 3 centimeters. That would determine the functional effectivity of this anastomosis.
Okay, 1 minute. So one thing is, I think your procedure was amazing. You did it really well and so fast. I think that's superb. My only argument is that we do a big anastomosis in a mini gastric bypass. With whatever I've heard from people is that they want their patient to eat, right?
Yes, yes.
So the whole logic is that the patient should be allowed to eat more because the procedure rests on malabsorption.
Yes.
And then we are adding a ring onto the procedure.
I'll correct you. I'll correct you.
Yes.
You
Yes.
said something which is wrong.
Really, I don't have that much experience in mini gastric bypass.
Gastric bypass is no more a malabsorptive procedure.
Okay.
If you are doing here a 180 centimeters of a bypass, let me tell you, we have with a 180 centimeters of mini bypass, which we have done, we have data to suggest that non-banded patients with a 180 centimeters of a bypass have 10 to 15% of a weight regain. And these patients also suffer from chronic constipation like our old sleeve and gastric bypass patients. So to me, a 180 centimeter of a mini gastric bypass or 150, which most surgeons are doing, Kamal has published a lot on it, behaves like a very large anastomosis gastric bypass. It has no difference. And we are seeing a lot of weight regain. And then those weight regains are because of very large pouch, which dilates over a period of time, and malabsorption, or what you say, I would not use malabsorption, the word. I would say that 180 centimeters of a bypass does not help in, preventing weight regain. Patient adapts to 180 centimeters of gut bypass frequently. So the principle, what you are saying, that MGB was made for patients to eat more, and it's a malabsorptive procedure, no more applies to this MGB which I created. This is just a 180 centimeters, and if you want, I calculate the common channel here. Not less than 800 centimeters would be the common channel. So this procedure is just like you may say a long pouch wide anastomosis gastric bypass, and therefore putting in a band here prevents the dilatation of the pouch above. So the entire concept which you say in this thing is a little different. We are not doing a malabsorptive procedure.
So Mohit, let us say if you were not doing a band here, then would you then do a longer, or would you say a longer BP limb would suffice instead of 180 at 200, or would you still say no?
If you don't do a band here,
yeah,
we can go reverse. We can just go and calculate a 350 centimeters of a common channel and then bypass the remaining length of the gut. So that can be one of the options for super obese patients, which we did, but then we do not apply the band. But if you apply a band here, a 180 centimeters is good enough as a bypass. And honestly, if you see, nobody is reporting the weight regain with the 150 to 180 centimeters pattern of MGBs. We have a 10 to 15% weight regain, and most of the patients then get their pouch redone with a band and sometimes even distalized, but very less number of cases, just resecting the pouch and putting a band gives them some additional weight loss. 180 centimeters to me in super obese patients like this is not good enough to be called or being eligible of a malabsorptive procedure.
Mohit, may I ask you that your Dr. Trivedi also presented that you took 180 centimeter for both one anastomosis as well as banded one anastomosis.
Yes.
In his prospective studies trial.
Yeah.
So
and
is there any difference?
Yes, absolutely. Yes.
No, for both, for one anastomosis or banded one anastomosis, you are taking 180 centimeter.
Yes, yes, yes.
Let's explain this. Basically, you guys read the reports from Dr. Robert and all the other centers where they're talking about the one anastomosis mini gastric bypass. One of the common complications and one of the reasons people do not like the procedure is the claim of, or the fact that there's a high probability of having protein caloric malnutrition. And as Dr. Kamal Mahawa has written extensively, people then tended to go away from 200 centimeters to 250 centimeters, which was what was recommended by OAGB Lee and other people who do various lengths for the MGB. So we decided to decrease the lymph length, pancreatic lymph length. But at the same time, as we studied our work, we realized that the super obese patients, even with 200 centimeters, were not losing as much weight, and some of them were regaining weight. So we knew that if we gave 180 centimeters to the super obese, some of them are going to regain weight and they're not going to have adequate weight. So we decided to do this as part of a study. We standardized the limb at 180 centimeters. And for the super obese, we offered them a ring based on the principle. That ring is not restrictive. The diameter of the MGB is 2.5 centimeters, and that ring, an 8 centimeter ring around the diameter, is 3.2. So in the first year, the patient doesn't even know they have a ring. You can't tell because the pouch is the pouch that anybody else has. So we want to make sure that we do not make it too restrictive, but at the same time, control weight regain later. If you looked at a presentation by Dr. Shashank, at 3 years, the super obese patients are still losing weight. We've not yet plateaued.
And on that note, so let us say if this was a 45 BMI Fobi, would you then do a 150 centimeter if this was a 45 BMI chap?
No, you do a 180 and you don't band it.
Okay, fine. And
we find out that in the patients in our study, which is going to be another topic, patients with BMI less than 50, that figure of 50 is arbitrary. Anywhere between 45 and 50, we consider anything 45 and below, definitely. Those patients have an average weight loss of 78 to 80% with a 180 centimeter BP limb. It's only the super obese that don't have that same amount.
And the question related to the placement of the ring, I mean, as you say, I think Mohit put it around 3 to 4 centimeter. Karl mentioned it around 5 centimeter. I think I remember either it is Clark or Sake's paper, you know, the first couple of papers, they mentioned 3 centimeter above the GJ anastomosis. So do you think that matters whether you put it from the OG junction or from the GA junction? In my head, I think if you put lower down, you have more chances of dilatation of the pouch above, is what I feel.
Well, I've talked to Clark and Booth about that. No, you want to put the ring as close to the GA junction as possible. Whether you're doing a gastric bypass, you're doing a sleeve, or you're doing a MGB, you want to keep it between 3 and 5 at most. I prefer 3 because Laplace law says the smaller the pouch, the less the likelihood for it to dilate. And then there's an anti-reflux effect by having that ring that higher up. It is not well documented, but we're studying that.
Dr. Fobi, may I ask you that now, today, what is your indication of banded vis-a-vis non-banded?
As super obese patients,
50, more than 50.
Do a sleeve, a gastric bypass, and MGB should be banded if the patient accepts it. Patients have the right not to accept it, but know that they have a high probability. Remember, we're dealing with probability here. The probability of regaining weight when you're super obese are high. And when you put a band-aid, you minimize it. You don't completely eliminate it. So I'm sure somebody's going to find a super obese patient who has a gastric bypass or MGB who has lost very good weight. But what you're saying that if you took 100 of them who are super obese and did a standard 180 centimeters, you might have about 20% of them, 15 to 20% regain weight. You want to minimize that because you want to limit the number of people who have to have reoperation. And the cost of placing the ring is less expensive than, even if you just have 10% of the patients that need reoperation, you take a large series, the cost of placing a ring in the other 80% is much less than doing a reoperation in the 10%.
And another question is that, for example, when you are going to remove, as he mentioned that there were 2 cases in which the band was removed. So only the band removal is to be done, or you have to revise the limb length also?
Well, Mohit, you want to answer that? Okay, he's not there. No, in that case, sometimes the patients develop intolerance. Most of them would adapt by nutritional counseling. But remember, you do surgery to improve the quality of life of the patient. So if the patient says, I find this unbearable, and you can go in with a laparoscope and cut that ring and take it out, that is fine. The beautiful thing which we do now, which is the topic of another thing, you very rarely have to do laparoscopic band removal. You can induce band band erosion by doing endoscopic dilatation or placing a stent. So any patient who comes in with food intolerance, if you place a stent, that band would erode. The pressure will cause necrosis, and you go endoscopically and remove it. In India, the cost is not much different, but in the United States, an endoscopy is like $1,500 to $2,000, but a laparoscopic surgery is $20,000. So if you're going to do an endoscopic dilatation and removing it, that's cheaper. So all of this depends on what country you're practicing. There are areas where the cost is so expensive, and there's somewhere doing a laparoscopy is not that expensive.
No.
So
my
on
question
that
was that when you are removing the band, you are just removing the band and that's it? Or you are going to revise the length of the segment also?
In most cases, when you're removing the patient has lost a lot of weight, you try to keep it, you just remove it. You take care of the problem the patient has.
Right.
The patient came in because they want to eat meat or whatever it is and they cannot eat it. Take it out, they have 180 centimeters, and you tell them you're going to regain weight, then they'll opt to do it. Because at that time, if you're going to revise, if it's a knowledgeable patient and really wants to be able to eat, then you want to revise them by revising distalization of the gastroenterostomy. Then you have to measure the complete small bowel and then start from the ileocecal junction and give them 350 to 400 centimeters. You do what Dr. Cabajo does, which is called an OAGB, a 60-40 lymph length.
Right.
and on
If you remove the ring, will you do will you convert to other procedures at the same time, or you just wait for a little bit, or just depends on the patient? They just want to take away the ring.
Very rarely. I mean, most rings are removed endoscopically, so you don't do anything.
And on that note, oh, sorry, Aparna, you want to
Sorry.
go ahead?
Yeah, Aparna has a question.
Just wanted to ask Dr. Fobi, so for a super obese patient, what would be your choice of procedure? Would it be, how would you choose between a banded RYGB or a banded OAGB? What would you prefer?
Dr. Bhatia can explain. We have an algorithm.
Yeah. So Aparna, we are not doing banded MGBs at our center. This we do only as a part of study. And as I rightly said that, as I said before, that MGBs to me are no more malabsorptive. We are doing 180 centimeters of bypass, and most of my patients, around 15 to 18%, have weight regain after MGBs also now. When we have become so, it's not, I was doing a 250 centimeters of mini bypass in 2013 and 14. And now when we have shifted to, and at best, these are 180. Sometimes they are even less, 150 to 1, because there's a 10 to 15% variation in even counting methods. So I would say that this mini bypass, which we make a long, large pouch, large anastomosis without a band, is proving to be a procedure which is giving some weight regain, which is like equal to a gastric bypass. I'm not finding it as strong as the older versions of the MGBs. So that's first. We are not bending our MGBs. We do only plain MGBs. We did this as a part of prospective study, which I think Shashank presented, and that's not a routine procedure at our center. Having said that, we have a clear algorithm. If the patient is super obese with a BMI above 50, then we need to consider whether the patient is a male or a female and the age of the patient. Most patients who are young, whose age is less, and who are females would still not get a mini gastric bypass, because females land up with a lot of anemia and iron deficiency, and I don't prefer to do it. We learned from our previous experience that has been a disaster. So we do sleeves, still would do sleeves. But if the patient is more than 50 years of age or 40 years of age, I would say severely diabetic. Pardon, sir?
If it's Dr. Parveen's age.
Yeah. I mean, old patients with severe diabetes, with a lot of insulin usage and super obese, yes, mini gastric bypass. Plus, I think it's very important, which Dr. Fobi taught me over the years. Please consider the compliance of the patient and the affordability of the patients for two things. The first is affordability to bear the cost of the supplements.
Correct.
And the second thing is compliance and the affordability to come back to you for a follow-up, which is very regular, because I saw that my 5-year-old MGB patients with 250 centimeters did very well until 5 years, and then landed up to me with ascites and liver failure. So when we do these procedures, even with limb length as aggressive as more than 200 centimeters, we have to be very cautious. So if we have, as I said, to just cut the long story short, the algorithm says that a super obese patient with severe type 2 diabetes, willing for a follow-up and can afford the cost of the supplements, gets an MGB. But if it's a super obese patient with, which is a young female or a young male, no, that should not be the preferred procedure. Forget about bending the MGBs. A banded MGB is purely investigational and a part of study.
Okay, that sounds fair. And I think I would once again like to compliment you on the beautiful surgery. I think it was totally very, very impressive.
No, I think the speed and neatness.
Yes, it was very nice.
Yes, I think that is always impressive. It just feels as if you are doing it in multiplied by 4 speed, to be honest.
Like an edited video.
It doesn't look, it looks surreal. A quick question to Mohit and Prof. Fobi here. I saw in that presentation by Shashank that you had 3-year comorbidity data, which obviously from 191, I think the follow-up patients were about 40 or 60, but at 1 year, you had still 190 or so impressive follow-up. Did you notice any comorbidity difference, mainly diabetic resolution in a banded or a non-banded bypass at 1 year?
No, there was no difference in terms of comorbidity resolution. I feel the take-home message here for banded MGBs is that it is, number one, investigational. We need to follow these patients up. Number two, I think definitely when you add a band, there is a stricture there. And that small stricture at just below 3 or 4 centimeters below, there's a small constricted area there. We see them on endoscopy, you can see that. And that restricts the eating of the patient. So for a mini gastric bypass, which has lost its strength of malabsorption, which is not the old Rutledge mini bypass, and everybody across the world is now so conservative after the study which has been published by our French colleagues that we are afraid to go beyond a 150. It is behaving like a long pouch gastric bypass without a diverted bile. So we are ending up having a gastric bypass with a long pouch. And that's why maybe by banding these patients, we are getting some better results, as Shashank has said, because definitely after 2 years, you go there, the band which is now loose will form a good capsule around that pouch. And there is a restricted eating in these patients as compared to the other MGB counterparts, that I can say. How long will this work? What repercussions which it's have? There's a small group which we can follow it up. Karl presented his own study where he had some problems. We might have some other problems in our own subset of patients, but we'll find the answer as we.
But the comorbidity
not for the prime time.
So initially, you don't think the comorbidity basically?
No. There is no difference in terms of comorbidities. I think most of the series in banded, non-banded, we have seen that it's the weight loss maintenance, which is more predominant. Only in our banded sleeve series, which we published in SORT, the 6 years data, there was interestingly some difference in terms of the lipids in the banded and the non-banded group. Otherwise, if I see the other groups, we haven't seen much of a difference in the two.
And on that, just that because you quote that paper, I remember, I think in that one, the ring you put it as 6.5 centimeter rather than 8. So is there a difference between that 6? Why do you choose?
No. We always use a 8 in sleeves. Oh. Always a 8. No.
Some authors put 6.5. Would you suggest that?
I have not used it. I think it's very restrictive. I don't use it. I usually use 8, 7.5. Even in gastric bypass, we use a 7 or 7.5. Also, that would depend upon how much fat my pouch has. Sometimes the pouch is thick. It has a lot of fat. I go a ring size above. My aim is to just let it be loose over the pouch. So size does not. If you have a very, very thin pouch, very slim guy, no fat on the pouch, you may get away with a 6.5, but I would not try that. It's too radical for me.
My Karl wants to ask something.
Yeah.
Can I? First of all, I want to congratulate Mohit for this nice procedure. Very nicely done.
Karl, if you remember, at your center in Cologne, we did a banded MGB.
Yes, very good.
So Aparna was not there, or she would have teared me apart. So, that day it was so interesting. So Aparna, I had around 150 MGB doers who are like, they love MGB like anything, and they started hooting me. I had to have a security. I had to ask for security in
Seriously?
Cologne to get out of the operating room because I was bending the MGB. And that MGB which Karl gave me to operate regained all the weight. You remember, Karl?
Yeah, yes,
It regained weight. We had to
Yeah,
resect
yeah,
the pouch. We had to resect the pouch. It's a large pouch we resected. And then we put a band. So Dr. Rutledge was furious. I mean, he did not talk to me for an entire year after that. Still not talking to me.
Actually, I have to add a question, Mohit. I have to add a question. What's about dumping with a banded procedure? Have you seen any less dumping with a bending, or any effect of the bend on occurrence of dumping?
So in gastric bypass between banded and non-banded, absolutely. Yes, there's very less dumping in the banded patients. I have to still go through my data for the MGB banded ones because we are still collecting a lot of data on them. But for gastric bypass, for sure, the banding prevents dumping. I cannot say the same for mini gastric bypass. I have to go through my data and check.
Because we have dumping, we have especially late dumping in the one anastomosis as well. No?
There's a lot of dumping. I had to, in fact, dumping is now one of the most common reasons I'm revising the mini gastric bypass. After doing it at 180 centimeters, we seldomly get any liver failures or more than 100% excess weight loss. Now we get weight regains, we get marginal ulcers, we get dumping, like you said, to revise these MGBs.
If you have dumping in a non-banded OAGB or MGB, are you putting a ring? Are you putting a ring?
No, I'm doing something more radical. Something more interesting. I started doing an endoscopic suturing at the pouch outlet, and I sort of restrict the size of the outlet, and I'm getting very well criticized for that. So just following up, but to be honest, me and Manuel, we did 10 cases in these 3 years. Dumping has completely is resolved with that.
Why not make it smaller to start with?
Yeah, that's the point. We can make it smaller to start with, but even though we make so small in gastric bypass, we still have dumping.
Yeah, we do have, yeah.
I have some patients, interestingly, who have dumping even with sleeves. I don't know. I have no reason. I have 5 patients who, one of the patients who had a dumping with sleeve, got a gastric bypass done from another surgeon for dumping, and is still dumping more than what he used to dump before. So it's interesting. We get these things, and what I'm doing now for dumping is that I first document it, and I think all of us are doing. We do a continuous ambulatory glucose monitoring, which is known as a CAGM. I have myself used that chip for 2 weeks, so now I know how the reading comes. I used it for my sports thing, but I give those patients, there's a chip which is put here. Anytime you want a blood glucose level, it comes on your mobile phone, and you get a 2 weeks data for all those patients who dump. So if we have the troughs of 40, less than 40 or less than 50, we would say, more than 15 times in a day in 24 hours, we are to revise these patients back for sure. I mean, because I discussed with a lot of endocrines, they say that if you have more than 14 troughs with this kind of going nadir down below 50 for 24 hours, you need to revise them back to normal enough. So
did you do the check endoscopy at the end of the procedure today?
Yes. Our fellow did. I came here, but the fellow did the check endo. I thought you were not interested in that. So
no, I just want to know that you are
we always do that. We always do that. We always do a check endoscopy in all our cases. We have, in fact, myself and Dr. Fobi, we are doing a study. Just after the procedure, we measure the pouch length. And Chetan asked a very interesting question, and these are the answers which we are responsible to give to the society, back to the bariatric society, that whether the length of the pouch above the anastomosis matters in preventing bile reflux. So everybody says make longest pouch, make it 200 centimeters long if you can, but whether that and all the published data says that 50 centimeters is the minimum length of the conduit required to prevent any reflux. Now, how it matters if you make 18, 13, 13.5, 14, 14.5, there's no logic to that. So what we are doing after every procedure, we are measuring the length of a pouch above the anastomosis by an endoscope and by the scale. And then we're going to follow these patients up after 3-4 years and present the data to you, whether really they have bile reflux of 14 versus 13 versus 12 versus 11 versus 10 versus 18. I don't think there will be any difference. Bile reflux or any reflux is a disease of lower esophageal sphincter, the weakness of the muscles there, and I think that's going to open the Pandora's box if we keep on discussing that. So
another small aspect of liver retraction. You said that you are using the 3 mm liver retractor.
Yeah, so that's an indigenous product we created. So you throw away your graspers after they are like 5 years old. So don't throw them away. Dismantle them, and you get a long rod.
Right.
The thickness of that rod is 2.2 millimeters to be specific. You can use that to retract your liver. So it has a hook. You can connect your. So I have 2 assistants these days. So one is Abhishek, the other one. So we are reducing the staff. So that 2.2 millimeter retractor, it retracts the liver, and you don't need a liver retractor like Nathanson's or anything. You can do any retraction with it.
Can you imagine? We have got the same Nathanson retractor with 3 mm fold, which can retract the liver.
Yeah. So
it comes out easily. There is no pain.
Yes. So what we realized that the Karl Storz end rod, which comes after dismantling the entire grasper, is very strong. You can even retract heavy livers. Plus, you have the freedom of changing your retraction as the passage of the case progresses. My operating time on an average for gastric bypass is 35 minutes, I've seen. So even if we have a heavy liver, I don't congest it. The pouch part is 15-20 minutes, so we can be fast, and that works. But if we have a longer operating time, like 2 hours or so for some surgeons, we need a Nathanson's. That's much better, because after a period of time, this won't work. This is if we have heavy livers. We are doing good with it as of now. Excellent. And I have not given, Dr. Fobi knows, I have not given liver preparation in last 15,000 bariatric procedures I performed, not to a single patient. Dr. Fobi knows that and when I used to speak about it, nobody used to believe me. Even for SILS, even for single incision bypasses or sleeves, we have never given any liver preparation. We just straight away go inside and operate. So with the same retractor which I demonstrated today.
Good, excellent.
Dr. Wang, any comments? Are you doing any anastomosis gastric bypass in China?
Just few cases, but we didn't put any bans on that. But may I ask Mohit, do you now routinely put bans on every OAGB patients, or you just?
No, I never put a ban on OAGB patient. That was a part of a study which we are doing, and we got an ethical clearance for that study from our in-house ethical committee, and it's also on the ICMR website. It's a part of study. We don't ban them. We are waiting for our 5 years to 10 years data. And then once the data will be out, like Shashank presented, we'll further keep on presenting this data, and then we will see.
So for now, do you think, are there any indication for banned OAGB?
I don't know. We have to see how we have to see more studies have to come. As Dr. Fobi said, I think it's not us. I think Almino is doing a study in Brazil. He has already collected, I had a talk with him 2 days back. He's collected 1 year's data. Karl has done one study. There are other colleagues from Australia who are doing a study. In fact, this year I was invited to Australia at 4 different centers to operate and demonstrate the banded mini gastric bypass. These guys are very fascinated with bands, so because they have seen the adjustable gastric band era, and they want this procedure to learn more about the procedure. But we because of COVID, it was not possible, and they have gone through my data. So everybody is on a stage of investigation. They are learning more. They are seeing. So I will give the answer to your question maybe in a future meeting in China, where I can present this 5 years or 10 years data at your center. So we know more about it.
And we don't have any bans here. So
yeah.
I remember a few years ago, I asked Dr. Fobi, do you have ever think about that? Set up some companies in China to promote your bans?
Once Mr. Trump leaves the office and we stop having fights with China, we might be able to work.
I can help if you want.
That's in the pipeline, yeah. We have that in the pipeline, definitely.
A quick question, Mohit. Since you just mentioned Almino's paper and study, I think he's the only one who has done the randomized control trial of 16 patients, banded and non-banded OAGB. And since you already opened the Pandora's box of reflux as well, as you said, he had, I think, as far as I remember reading that paper, about 18% and 15% vomiting and heartburn episodes in his banded and banded patients. And I think it stayed at around 12% at 1 year follow-up. Have you noticed that, or you, because you do a loose ring and stuff, you have not noticed reflux or heartburn problems in your 1 year or 2 year data? And what do you do different, you think, compared to them if your reflux rate is low? Or for example, do you give them long-term PPI or something? That's what I wanted to know.
So PPIs we give to all the patients, even if it is banded or non-banded, and that's lifelong PPIs. That's most patients would not take it. Sometimes they leave it after 6 months, or it's there. This thing we suggest them to take PPIs. I never had that. So we had problems with bands and MGB, but not the problem of more reflux. But whenever we had a problem, we had some strictures, maybe a ring displacement or a ring slippage. But we never had extraordinarily more reflux with the banded MGBs. The reason I feel we did not have is first is obviously the ring is a little loose, and by the time it is loose, it creates a capsule. That capsule is also not as tight as maybe creating a lot of stricture or creating a lot of obstruction to the distal flow. That can be one of the reasons. The second reason is, I think, heartburn and pyrosis and all these problems, they are not because of bands. They are because of bile reflux. So some patients have bile inside their gastric reservoir. They react very differently. This bile, which comes inside the pouch, can cause very severe bile gastritis in some patients. And in other set of patients, it does not cause any bile reflux gastritis, despite bile being inside the pouch. So when I do an endoscopy, I have interesting findings. We see the bile inside the pouch, yet there is no symptom. Sometimes we see no bile inside the pouch, yet when we take biopsies and other stuff, we see that there is a lot of gastritis and a lot of other issues which are present. So I think that's the answer to your question, is why as far as our study, we don't see a lot of difference between the two counterparts. But still, I think we should follow them up. Maybe a 5-year or an 8-year data can give us more, honest results.
Agree. Mainly because, as I mentioned earlier, we always talk of reflux and issues with MGB and then putting a band. I think it would be interesting to have if
you put a loose band, I don't think it's going to create a lot of issues in terms of reflux. Bile reflux with MGB will be a problem. And those patients who are having it, I think they need attention, because if we have bile which is coming into the esophagus while we do an endoscopy and we see bile in the esophagus and patient is reporting a lot of symptoms, and even in asymptomatic patients, I think that can be very hazardous, because esophagus is not meant to see bile. Yeah. If it is seeing bile every day, that's a good ground for having a Barrett's or maybe a malignancy. So we don't know these things. I would agree that I am not.
When you deal with the MGB, the problem we have had is lack of studies and lack of objective documentation. The problems we have is with doctors whose only operation they do is an MGB. They do an MGB on everybody. When you have an algorithm and you have a patient with GERD, a hiatal hernia, esophagitis, you don't do an MGB in them. And if you can look at it, we are reporting a series with almost 131 and 191 cases. We have not reported any patient with reflux after the operation. It's not that we don't have it, it's because the facts and the science are going to show that the patients who have those things had it before, or they had dysfunctional lower esophageal sphincter, and people don't want to take the time to study it. So we do not offer MGBs or sleeve gastrectomies with patients who have lower esophageal dysfunction, or have hiatal hernias, or have a propensity to have heartburns or regurgitation. In those cases, you go ahead and do a gastric bypass, so you automatically reduce the number. Number two, I say this because we're just collecting the data, but my initial impression, Mohit will tell you, when I came, he was more inclined to do hiatal hernia repairs and fix the hiatus. Don't mess around with the hiatus. Don't fix it if it's not broken. A lot of doctors are causing dysfunctional lower esophageal sphincter by doing dissection around the esophagus and telling me they're doing a hiatal hernia repair. Parveen would tell you hiatal hernia repair has never been a treatment for reflux. So we have a new set of bariatric surgeons who are inventing medicine. If you go down close the crura, it was never, has been documented, never to be a treatment for reflux. Reflux is a pathology due to the esophageal sphincter or a hiatal hernia with most of the stomach in the pouch in the upper chest, and so you have some regurgitation. So if you don't mess around with that gastroesophageal junction, you will not have problems with sleeve. That's why you see a lot of doctors are having this high incidence of problems with sleeve, because they go there and mess around with the gastroesophageal junction. The patient had no problems, you caused the problem. The problem is we don't keep data and we don't report them, and we just, we let that go. We should keep the data, and with time we'll find out that we're creating problems. The last point I'll make is to answer Dr. Parmar's question about resolution of comorbidities. At 1 year, you don't see much, but by 2 and 3 years, there's a difference between the resolution of comorbidities. They are better off in a banded procedure because it's proportional to the weight loss and maintenance. If you see it at 3 years, you look at about a 26% versus a 33% total weight loss. Those patients have a better resolution of type 2 diabetes maintenance. And 4 years down the road, you're going to see the same. Finally, Dr. Bhandari was alluding to the other study we're doing. We're studying the pouch of MGBs 1, 2, and 3 years in a surveillance study. So we're finding so much variability. So if you have a short pouch and you don't have bile in the gastric pouch, you have no problem. If you have a long pouch and you have bile in the gastric pouch, then you have dysfunctional problems. So there are things which people just claim, make a long pouch. The last point is, everybody talks about a long pouch. The stomach is proportionate to the height of the patient. So for everybody to say you're going to make a 17 to 18 centimeter pouch, they're just lying. Once you start measuring that pouch, the best way to make the best pouch is to make the longest pouch. The longest pouch is to take a fixed distance from the pylorus, 2.5 centimeters proximal to the pylorus, transect your pouch. Then you've given the patient the longest pouch you can give them. If you just go below the incisura, like everybody says, some patients who have a short stomach will have a 9 centimeter pouch. Those who have a long stomach will have an 18 centimeter pouch. That is why I preach that doctors say one thing and do another. And the only way you're going to know what you're doing is by measuring it. You're going to have a doctor who says, I'm using a size 40 bougie, but places the staple so close that he ends up with a tube which is 2 centimeters in diameter. And then you have another doctor who puts a size 32 bougie, but staples so far away that he ends up with a pouch which is 3 centimeters in diameter. But if you take the time to measure it, after the first 50 days, you know what you're doing. So measure what you do, keep the data, and then you're going to come up with your own findings. I was going to ask Karl, what do you think about the fixed bowel length in the OAGB or the BOAGB one anastomosis gastric bypass? You see that, Dr. Rheinwalt?
Yes.
What do you think about it?
I gave a presentation on Thursday in the Frankfurter meeting about this.
Okay, all right. No, what? Just give us a highlight.
It's contradictory. It's a question whether we should adapt the length to factors like age, like BMI, or like the total bowel length, or if we go and do a fixed length. Yeah, two different approaches. But actually, we don't have any study comparing this tailored limb OAGB and the fixed limb OAGB. We don't have a study. We have a lot of controversial papers, but we don't have much evidence.
Thank you. Mohit, you have any other comments, and then we'll close?
No, I think that's a great discussion we had. There are 2 points which I would want to make. The first is that the MGB as a procedure has changed. I had a discussion with a lot of surgeons who are doing a high volume MGBs in India and across the world, who are doing at least 20 MGBs a month, and most of them are getting very particular about their limb lengths. They are now doing 150 centimeters. Like I think Chetan also does the same. I think Kamal is doing around 150 to 180. I heard Dr. Tantia start 150 centimeters. There are others, colleagues from Gujarat, from Mumbai, from Ahmedabad, everywhere they have gone very less on these limb lengths. It would be very interesting if 3 years from now, we also share our data of weight regain after mini gastric bypass, because that is something which is going to happen. Once you go with this sort of limb length, with such a long pouch, large pouch, I would say, we're going to have some weight regain. And I can say that that weight regain is going to be equal to your gastric bypass, if not sleeve. Obviously, sleeves are going to be the king of weight regains. All of them are going to come back. But we're going to have the same weight regain with, as far as our data is showing, with like a gastric bypass, which is non-banded. Now at that stage, when we were reducing our limb lengths, we knew that we're going to have some lesser weight loss and some lesser weight loss maintenance. That was a trade-off. But when these patients are going to come back to us with weight regain, what solution do we have for them? That is what one thing which we have to think, because that's going to come as your number of MGBs with lesser and lesser limb lengths going to increase, number one. And number two, banded mini gastric bypass is purely investigational. I would think that centers with high volume should do some cases and follow them up, keep the data and present them up in a very fair and honest way in future times to come, so that people can learn from it. That's my only message.
Man, Fobi, I would love to say the same thing which you have said. You cannot manage what you cannot measure.
Absolutely. That sounds like Dr. Bhatia.
Yeah.
The man with the wisdom. Well, thank you all very much. We know you have a very busy schedule. We're glad you shared this with us. This has been recorded. It's been on Facebook. I got a note that we're streaming to about 500 or 600 people on Facebook.
Yeah, this is live on Facebook, LinkedIn, YouTube, everywhere.
Yeah, so we're getting a lot of exposure. This is going to be on the VBO website if you want to look at it later. And then Winnie, Himanshu, do we have a webinar next week? And what's that about?
Yeah, so we have a webinar next week, and I'm going to just start the video as a promo to that. This is the video.
Thank you. Thank you. Thank you.
Namaste.
Namaste.
Thank you, everybody. Thank you.
Thank you.